Hello, everyone. Welcome to our presentation today on emerging treatment for blood cancers and diseases as part of our Indie Hematology Review Evening with the Experts. I hope that in the future we'll be able to do this again in person, but we are appreciative of the fact that you're able to tune in today and watch us via Zoom. So without much ado, let's share some data that have been presented over the past year for the treatment of blood cancers and diseases. This is just to acknowledge the Indie Hematology Education Board of Directors, a nonprofit organization whose aim and goal is to promote hematology education both for providers, physicians, caregivers, and patients. And our motto is achieving tomorrow's outcomes today through education. So I'd like to talk about acute leukemia. What is acute leukemia? These are diseases of the blood where there are blood cells that are immature, referred to as blasts, and can cause death, obviously. And the current treatment of acute leukemia frequently will result in patients who are not cured, unfortunately. And in order to prevent recurrence, one of the strategies that's been used is so-called maintenance therapy. So there is a new drug, CC486, which is approved as a maintenance therapy for patients who have acute myelogenous leukemia. But the strategy here is to see what if you were to use this very early on when patients have completed their treatment, when they have very low amounts of leukemia cells in their bone marrow, can you use this drug to decrease the chance of relapse? And the answer is yes, which was shown in this clinical trial. And we were able to show also that minimal residual disease, which is the ability to have very small amounts of leukemia in the bone marrow or in the blood, was enhanced significantly by using this drug earlier to prevent recurrence. Another strategy is to use a drug called glutarate, which is a drug that is currently approved for patients who have FLT3 mutations in the relapse setting. But when you combine this with chemotherapy, 82% of those patients achieve a response, with most of them clearing the leukemia in their blood. But we do know that one of the ways that leukemias and other blood diseases escape or are not cured is that they are able to evade the immune system. What if you were to enhance the immune system? It turns out that there is a protein in the immune system that is produced by leukemia cells that is targeted by the leukemia cells. And that protein is sent a signal by the leukemia cells, don't eat me. So think about it for a moment. Leukemia tells the immune system, do not eat me. And so the leukemia is left alone, unabated, to kill the patient. What if we were able to target that signal that tells the that tells the immune system not to eat the leukemia? The do not eat me protein is targeted. That's called CD47. And magrolimab, in combination with azacitidine or chemotherapy, when used in this particular case, resulted in a 68% of the patients achieving transfusion independence, with 55.4% of the patients achieving a response. Flotuximab is another strategy of using an immune engager in the treatment of acute myelogenous leukemia. And in this particular case, you see that 26% of the patients responded. Acute lymphoblastic leukemia is the other form of acute leukemia. And hypercivil is a commonly used form of chemotherapy. And blinatumab is an immune engager that is currently approved for the treatment of acute lymphoblastic leukemia. It targets CD19, and in combination with hypercivil, which is a commonly used chemotherapy regimen, results in 100% of those patients achieving a clinical remission, with 97% of them having no detectable acute lymphoblastic leukemia. Another strategy that's been developed is a way to avoid bone marrow biopsies using the so-called clonoSEQ minimal residual disease detection technology. This is a technology that can look at blood and detect recurrence in the blood without the need for a bone marrow biopsy, which really is a very important step in the management of patients with leukemias, where the dreaded bone marrow biopsy could be avoided, and you can use a blood test to detect who has residual leukemia and treat them at that point. We just talked about acute leukemia. What are chronic leukemia? Chronic leukemias are similar to acute leukemias, but the cells that are involved here are more mature forms. And you have two major types, chronic myeloid leukemia and chronic lymphocytic leukemia. And chronic leukemias can transform into aggressive leukemias. Chronic myeloid leukemia, as you know, is a disease that is currently treated with drugs that are referred to as tyrosine kinase inhibitors. Most commonly referred, or the most commonly used drug in that class is a drug called Gleevec, and there are similar drugs which are very similar to Gleevec. But these drugs work differently. The current drugs work by inhibiting the so-called ATP pocket of the protein that's abnormal in chronic myelogenous leukemia, the so-called ABL1 protein. Asciminib is a drug that targets the myristoyl pocket of the ABL1, which is different from the ATP pocket. And in patients who have previously been treated, we have responses of about 25% of them responding. There are some arterial occlusive events that are associated with this agent, but I expect that this drug will be approved very quickly and soon as a treatment option for patients who fail prior therapies for chronic myeloid leukemia. Ponatinib is another drug that's currently used for chronic myeloid leukemia, and it's used for patients who have a mutation that's referred to as T315I. But those patients are frequently at risk for developing some adverse reactions that are referred to as so-called arterial occlusive events. And if you were to use ponatinib on a continuous basis at a high dose, the likelihood is higher. So this study looked at using the high dose and then de-escalating the dose in patients who respond, and you can see that the patients who were treated with high dose and then de-escalated did very well. So that's another potential opportunity for treatment of chronic myelogenous leukemia. Chronic lymphocytic leukemia, on the other hand, is a different disease, and the treatment for chronic lymphocytic leukemia involves pirtobrutinib, which in this particular study, pirtobrutinib is a newer generation TKI or protein tyrosine kinase inhibitor. In patients who have previously been treated with other protein tyrosine kinase inhibitors, for example, ibrutinib, acalabrutinib, or zanubrutinib, and using this drug, which is made by Eli Lilly, pirtobrutinib, so-called LOXO-305, we were able to show responses in 86% of the patients. So using another tyrosine kinase inhibitor for patients who have now developed resistance because they have a mutation of this so-called CYS481S mutation, you can show that pirtobrutinib is quite effective. But another strategy is to use the so-called CAR-T therapies, where we take your own immune cells and educate them and make them more active and become activated T cells. And when combined with ibrutinib, you see that 95% of these patients responded. Another strategy is to use a newer form of drugs that is referred to as PI3 kinase. So umbralisib is a PI3 kinase with ublituximab, which is another monoclonal antibody that targets CD20, which is present on CLL cells, and obinutuzumab. And you find that if you combine umbralisib and umbralisib versus obinutuzumab versus chlorambucil, you see that patients' response rates are significantly higher compared to obinutuzumab and chlorambucil. So again, another monoclonal antibody with umbralisib showing very robust activity in this refractory group of patients. What of in patients who have been treated with prior tyrosine kinase inhibitors or chemotherapy? If you use acalabrutinib plus venetoclax, which is currently approved, versus obinutuzumab and Rituxan, you see that the acalabrutinib and venetoclax is quite effective. In ELEVATE-RR, we're combining or comparing two different tyrosine kinase inhibitors, acalabrutinib versus ibrutinib, and what you found was that they were equivalent in efficacy, but different profiles in toxicities, as you can see here. And in the Alpine study, zanubrutinib, which is another TKI or another type of protein tyrosine kinase inhibitor versus ibrutinib, also showed different toxicity profiles and different results in terms of efficacy. And so the bottom line is that these really allow us an opportunity to choose for different patients based on their comorbidities, whether to use acalabrutinib, whether to use zanubrutinib, or whether to use ibrutinib. So it really gives us a whole host of options in our toolkit. In the first-line setting, one of the key questions is how best to treat patients with chronic lymphocytic leukemia. Do you treat them on a continuous basis, or do you treat and stop and then wait for patients to relapse? And one of the strategies that has been looked at is ibrutinib and venetoclax versus traditional chemotherapy. And so these two studies One was presented at ASCO, looked at ibrutinib and venetoclax in a phase 2 study, and then the other is the GLOW trial, which was just presented at the European Hematology Conference. And what you see here is that the combination of ibrutinib and venetoclax in fixed duration therapy is more effective than traditional chemotherapy, and it's an option for patients, and you can see that difference here. So I really believe that these options will be approved and become available very soon for treatment of our patients. Lymphomas are different diseases. These are diseases of lymphocytes and lymph nodes, and there are two major subtypes: Hodgkin's lymphoma, which is named after Sir Dr. Thomas Hodgkin, the British physician who described it, and then non-Hodgkin's lymphoma, which is the other type, which is the more common type. And these are the treatment options that have now become available or potentially will be available. First is bispecific antibodies. These are immune engagers. You make an antibody where one arm of the antibody attracts the immune cells and the other arm attracts the malignant cells. So essentially, you bring the immune cells to the malignant cells, and that results in killing of the malignant cells. Mosunetuzumab was looked at in refractory follicular lymphoma, responses 67%. Udronextamab, which is a human bispecific antibody, also had very high response rate. And the CAR T therapies, which I mentioned earlier, in this particular case, in the Transcend study, you see that in relapse refractory mantle cell lymphoma, patients responded. 84% response rate was the overall response rate in mantle cell lymphoma. This is a disease that's typically difficult to treat, particularly in the relapse setting. And then another form of treatment is to use the so-called anti-CD19 antibodies. So CD19 is present on lymphoma cells, but typically not targeted because most of our treatments target CD20. But CD19 targeted by tafasitamab with Revlimid resulted in a 55% response rate, responses lasting for up to 44 months rather. And in the Lotus-2 trial, this is using a new drug called loncastuximab. Loncastuximab is an antibody that is linked to a cytotoxic drug, so so-called antibody drug conjugate, and response rates were 48%, duration of response about 13 months at this point. Umbralisib, which is a PI3 kinase inhibitor, PI3 kinase delta is one of the pathways that is dysregulated in lymphoma. Used as a single agent, had response rates of about 47%. Another PI3 delta kinase inhibitor, parsaclisib, had response rates of about 57%. And the drug that I mentioned to you earlier, pirtobrutinib, which is an protein tyrosine kinase inhibitor, which is a new generation protein tyrosine kinase inhibitor targeting mutant patients, used in patients with Waldenstrom's macroglobulinemia, including patients who have been pre-treated with protein tyrosine kinase inhibitors, responding about 69%, which might be an option for patients with Waldenstrom's macroglobulinemia, particularly after failure of prior therapy. And in Kronos trial, here they looked at copancelate, which is another tyrosine kinase inhibitor. Here is a pan-tyrosine kinase inhibitor with rituximab, showing very robust activity in lymphomas and also Waldenstrom's macroglobulinemia. In Hodgkin's lymphoma, drug brentuximab vedotin, which is an antibody drug conjugate, combined with immune therapy in patients who are not candidates for chemotherapy, resulted in a 92% response rate. Again, another potential option for treatment of Hodgkin's lymphoma. Myelodysplastic syndromes are diseases that patients are not quite at the leukemia phase, but they can transform into leukemia. You have immature cells, and there are 7 different subtypes. And the current standard of care is to use so-called hypomethylating agents, which are drugs that block the maturation of those cells to become leukemia. And axitinib is a drug that targets a protein called IDH2, which is present in a significant number of patients with myelodysplastic syndrome. And in combination with azacitidine, which is a hypomethylating agent, 84% of those patients responded. Another type of similar drug is called ivosidenib, which is an IDH1 inhibitor. And in this case, combined with chemotherapy, you see that response rates are also very robust. But another way of treating these patients, especially patients with low-risk MDS, where anemia is their main manifestation, is to block the proteins that prevent the patients from producing red cells. So one of those so-called proteins is the hypoxia-inducible factor propyl hydrolase inhibitor, and you can see the response rates of 38%. The Dakota trial, the main purpose here was to look at hydria versus decitabine, and similar response rates were higher with decitabine, but overall survival was similar. And a new form of therapy is the so-called tri-specific killer engager. Here, instead of targeting the immune cell and the malignancy, here you're really targeting two immune cells, and the malignancy, again, showing very robust activity with this so-called trike. In myeloproliferative neoplasms, which are diseases that are treated typically with so-called JAK inhibitors, ruxolitinib being the most commonly used one, but ruxolitinib combined with a BET inhibitor, which is a new form of therapy, showed very robust activity. And imetelstat, which is a telomerase inhibitor, was also found to be effective in patients who have been treated with ruxolitinib and are resistant to ruxolitinib. And luspatercept is another anemia treating drug that has been found to be effective in myelofibrosis, and potential option for patients who are resistant to current erythropoietin agents. Multiple myeloma is the disease of the plasma cells, where the plasma cells accumulate in the marrow and can cause destruction. And we do know that current treatment, when patients become resistant, are very limited. So CAR T therapies targeting BCMA, which is a protein present on myeloma, you can see 3 different CAR T therapies targeting the BCMA are quite effective. And bispecific antibodies targeting BCMA, you see 3 of them here listed, quite effective, and you can see the efficacy of the data, as you can see up here. And then what of patients who have relapsed refractory disease targeting BCMA with the so-called antibody drug conjugate? There are 2 of them. One of them is already approved in combination with bortezomib and dexamethasone, is quite effective, and the other is a humanized BCMA antibody, and you see response rates of about 66%, the so-called MED12228. So very effective drugs in treatment of refractory myeloma. And then if you look at the non-BCMA targeted antibodies, again, the bispecific antibodies targeting non-BCMA, in this particular case, you see GPCRD5 has been targeted, or FCRH5 being targeted, and you see the robustness of those activities. Immune modulating agents like Revlimid are currently used in treatment of multiple myeloma, but iberdomide is a newer generation drug and has very robust activity. Another strategy for treatment of multiple myeloma, however, is to inhibit the exportation of the tumor suppressor genes out of the nucleus of the myeloma cell. And so the drug that is currently used in that case is called selinexor. Tumor suppressor genes tell the cells to die, and when they are exported out of the nucleus, the cells do not die. And so if you inhibit that exportation, you now restore their sensitivity to chemotherapy, and you can see that here, and the patients have response rates that are rather robust. Daratumumab, which is an anti-CD38 antibody, is now approved in a subcutaneous fashion, which allows for quick delivery to patients. And you can see here with pomalidomide and dexamethasone, robust activity. Similarly, isatuximab is another CD38 antibody in combination with kyprolis or carfilzomib and dexamethasone, very effective in the treatment of multiple myeloma. In the treatment of early stage multiple myeloma, you see very robust activity, response rate of 66% in the MAIA trial in patients who are transplant ineligible, and you see there's an overall survival benefit using a 3-drug combination of daratumumab, lenalidomide, and dexamethasone versus lenalidomide and dexamethasone. Griffin trial used daratumumab, a so-called 4-drug combination with VRD, and then maintenance, again, robust activity. Similarly, the Forte trial using KRD with or without autologous stem cell transplantation, and KR or R maintenance showed the superiority of KR maintenance and superiority of the KR containing regimens. And benign hematology, just to quickly finish, the BTK inhibitor, rilzabrutinib, is being used for ITP with results of 42% relapse refractory ITP, and for patients with refractory ITP using mycophenolic acid and steroids is also effective. And in patients with sickle cell disease using an anti-sickling agent is effective. As you can see here, this is the metapivat drug. And using gene therapy in patients with severe hemophilia, quite effective. And in the Pathfinder trial, avapritinib is effective in treatment of mastocytosis. And a newer drug for the treatment of PNH pegacetabine, quite effective, as you can see here. And then pozapinib, also for the treatment of hereditary hemorrhagic telangiectasia at much lower doses than is used for solid tumors. Transplant, you see here, using a reduced intensity transplant can be quite effective in patients with MDS who are not candidates for high dose chemotherapy. And a universal CAR T therapy is also being used for the treatment of patients with BCMA CAR T, using a BCMA CAR T therapy approach for the treatment of relapsed refractory multiple myeloma. Similarly, you can see that in the CLIMB trial, using a CD34 antibody can be quite effective using the gene therapy approach for the treatment of sickle cell disease. And in graft-versus-host disease, you see the different strategies, either using itatinib, which is a newer JAK inhibitor, or baricitinib, which is another JAK inhibitor. It's also quite effective. And in the ROCKSTAR trial, using the selective ROCK2 inhibitor, quite effective in treatment of graft-versus-host disease. So with that, I'd like to tell you to save the date for our next meeting, which hopefully will be on March 25th of 2022, again at the Westin Indianapolis Hotel, and hopefully that will be a live meeting. Thanks for listening, and we do have a very robust faculty today that will be discussing all of the other diseases ranging from lymphomas, myeloproliferative disorders, leukemias, and multiple myeloma and Waterstone's macroglobulinemia. And finally, I want to acknowledge and thank our sponsor. Our main sponsor this year is Community Health Network, in collaboration with MD Anderson for this meeting. And remember that this meeting was organized by Indie Hematology Review and Indie Hematology Education. So thank you so much for your attention, and I look forward to seeing you hopefully in person next year. And I hope you enjoy the rest of our presentations.